Now let us start with blood transfusion. So first of all, what you have to know that we have a blood bag which is for 350 ml and 450 ml. 350 ml we are using for the blood donation, whereas 450 we are using for the platelet. Right. Then in the blood bag there are certain contents. What are they? They are ACD, CPD, CPDA or SAGM. Right. So these are the contents which are used for storing of blood. Acid citrate dextrose has half-life of 21. Citrate phosphate dextrose has 28 days, whereas CPDA, where adenine or adenosine is added, that has 35 days as shelf life, and it is the most commonly used. SAGM, that is the saline adenosine glucose mannitol, that has a half-life of 42 days. So two questions, okay, shortest half-life, most commonly used, longest half-life. Right, now coming to the functions. So please know beta 21, 28, 35, 42, they are all table of 7. Right, so remember that ACD has minimum, now it is not used. Okay, for the contents, please know citrate is added because it is an anticoagulant. Phosphate is added to act as a buffer. Right, dextrose is added because for the maintenance of red cell membrane and metabolism. Adenine or adenosine is added because it is an energy source for ATP generation. Glucose is also a source of energy, and NaCl is added for isotonicity. Right, so this is very important. Shelf life, minimum, maximum, mannitol. Why mannitol is added? Because mannitol prevents hemolysis. All of this is a question. How do you select for emergency transfusion? And if the patient blood group is known, then what do we use the blood group of the same group should be used. If the patient's blood group cannot be determined, then group O RBCs are chosen, and the unmatched blood should be Rh negative when used in a woman of childbearing age. Okay, because we don't want the Rh sensitization to occur, and Rh positive blood can be used if Rh negative blood is not available for older females and males. See, you have to save life. So if possible, we should not use the Rh positive blood, but if it is not available, then we may use it. Okay, next, what do we check for in the sample? We send the sample for checking of certain diseases. They are HPV, HCV, HIV, malaria and syphilis. So very important question, for which of the following we do not test the blood sample? So HBA, hepatitis HVA, that is the hepatitis A, we don't check. Okay, then CMV, HTLV and parvovirus, they are the diseases which can be spread through blood. Okay, so but we are not checking for them. We are checking for especially HBV, hepatitis B, hepatitis C, HIV, malaria and syphilis. Okay, next, what is the criteria for donor selection? The donor's age should be 18 to 65. The weight should be more than 45. Blood pressure should be controlled. No skin disease at the phlebotomy site. And if he is a avid blood donor, then between the two donations, 3 months gap has to be there. Whole blood donation to be deferred for 3 days after plasmapheresis. Donor should have eaten something in the last 3 hours. Okay, so this is the criteria. Who is the universal donor? O negative. Who is the universal recipient? AB blood group. Okay, next, first let us come to this chart, everyone. Okay, now seeing this site, whole blood is stored at 2 to 6 or 2 to 8 degrees C's and its shelf life is 42 days. It is used for acute blood loss or exchange transfusion. Packed cell RBCs are also stored at 2 to 6 degrees C's. If it is asked, please remember whole blood at 4 degrees C's. Okay, then shelf life is 42 days. It is used in severe anemia. Like platelets, they are stored at the room temperature 20 to 24 degrees C. Their shelf life is 5 days. Okay, indications are thrombocytopenic conditions like dengue, hemorrhagic fever. Right, cryoprecipitate is stored at -30 or lower. Right, even -18 degrees C. Shelf life is 1 year, and cryoprecipitate, we all know it is a rich source of factor 8 and Von Willebrand factor. So we use it in hemophilia A, we use it in von Willebrand disease, we use it in factor 13 deficiency, we use it in fibrinogen deficiency. Fresh frozen plasma is also stored around at minus 24 degrees C. Shelf life is also 1 year, and it is used whenever there is loss of any clotting factors except 5 and 8. Okay, so it is not used in that. Next, for whole blood, you require ABO compatibility, Rh compatibility. Packed red blood cells, ABO and Rh compatibility is needed. For platelets, only ABO compatibility is needed. Cryoprecipitate can be given of any group, so no compatibility needed. For fresh frozen plasma, again ABO can be needed. Okay, now single unit blood transfusion will raise the hemoglobin by 1 gram per deciliter and hematocrit by 3%. So this chart is almost similar to the chart on the right side, so it is okay. Okay, next is this beta. If suppose we have to do RBC transfusion, then it has to start within 30 minutes. It has to start within 30 minutes of taking it out from the blood bank, and it is to be completed in 4 hours. If suppose someone needs platelet transfusion, then if you take it from the blood bank, it has to be given immediately. We don't store it. It has to be given immediately, and it has to be completed within 30 minutes. Fresh frozen plasma also has to be given immediately and completed within 30 minutes. So there was once a question, if a patient needs both platelets and PRBCs, then what will we give him first? We will first give him platelets, because beta immediately we have to give and has to be completed in 30 minutes. Then we will give him PRBC, right? Because for PRBC we require longer time. Fresh frozen plasma, everyone. Now this is very important. Fresh frozen plasma, let us quickly revise what it is. It is produced from separation of plasma from the donated blood. It is stored at minus 18, minus 24, minus 30, whatever degrees C, and each unit will contain 200 ml, right? And each unit will have clotting factors, so it is given in clotting factor deficiencies, right? It can be given in DIC, right? Next, it is lacking the 5th and the 8th, right? So it is used for correction of coagulopathies except 5th and the 8th. Okay, and even treatment of TTP, wherever the coagulating factors, they are absent. FFP should not be used to expand blood volume, and since FFP is an acellular component, so it does not transmit the intracellular infections like CMV. Now cryoprecipitate, normally it is 10 to 20 ml stored at minus 30 degrees C. Cryoprecipitate is a rich source of 1, 8 and von Willebrand factor and not of 9. Right, a unit of cryoprecipitate will be provided for either prophylaxis or treatment of these disorders. Right, so please remember this. Next. Okay, next is platelet concentrate. See, volume is around 50 ml. Platelets are only blood products which are stored at room temperature, and their survival is 4 to 5 days. Since they are stored at room temperature, they are most susceptible to transferring of infections. Okay, next, 1 unit of platelet increases the platelet count by 5,000 to 10,000, or some books say 5,000 to 7,000. Right, threshold for prophylactic platelet transfusion is 10,000 per microliter. This should have been the patient's platelet count. Right, next, transfused bloods generally survive for 2 to 7 days, and ABO compatibility is desirable but not necessary. Right, and blood platelets in stored blood are non-functional after 24 hours. Now everyone, in a stored blood, we see no WBCs after 24 hours, no platelets, they die after 24 hours. We see increased potassium, decrease sodium, and single unit of blood increases hemoglobin by 1 gram per deciliter. Right? Okay. Next is the various adverse effects which can occur because of transfusion. So transfusion related problems, right? Then what can happen? They can be immediate or they can be delayed. Immediate can be hemolytic or non-hemolytic. In non-hemolytic, please remember FNHDR is the most common. In non-hemolytic FNHTR, allergy, anaphylaxis, trali, taco. Right, we will tell you what it is. In delayed, it occurs after 24 hours. Immediate is before 24 hours. Delayed complications after blood transfusion can be hemolytic, GVHD, post-transfusion purpura, and disease transmission. Right, in hemolytic, obviously hemolytic is occurring because of ABO incompatibility. Right, so let us start with the most common one, which is the FNHTR, febrile non-hemolytic transfusion related reaction. Now this is most common. It is due to cytokine release. It is due to antibodies against donor lymphocytes. To decrease FNHTR, we use leucofilters. And beta, this question had come, what is this thing? This is leucofiltration appliance, and they ask what is happening. So leucofiltration is happening. Why? To reduce the febrile non-hemolytic transfusion reaction. Understood? Next, please let us go over these points. FNHTR is the most common blood complication. Trali, I will tell you what it is. It is seen most commonly with FFP. It is the most common cause of death after transfusion by FFP. Infectious complications are most common with platelet preparations because they are stored at the room temperature, and most common cause of hemolytic transfusion reaction is clerical error. And red cell substitute include hemoglobin solutions and perfluorocarbons. Now what is trali? Trali is transfusion related acute lung injury. It is ARDS, okay, respiratory distress syndrome. Now trali, it develops within 6 hours of transfusion. It is a cause of non-cardiogenic pulmonary edema. Fresh frozen plasma is the most common cause. It is most commonly seen after sepsis and cardiac surgery. Clinically, beta, ARDS occurs. Trali, please remember, it occurs within 6 hours, so immediate, and it is occurring in FFP. Right, and please remember, it is also caused by antibodies against the HLA. Right, and where will be the antibodies against HLA be present? They are present in the multiply transfused person who's giving blood, or a person who, or a woman who has had multiple pregnancy. So how can we avoid trali? We can avoid trali by not taking blood from a person who has already had multiple transfusions, or who had already been pregnant multiple times. What is TACO, everyone? TACO is transfusion associated circulatory overload. Circulatory overload, that means it is going to happen in cardiac patients, anemic patients, patients who have been on dialysis, okay, who are already under cardiac distress. When do we say a patient has TACO? Immediate kind of a feature it is. So any 4 of the below, which is increased BP, tachycardia, acute respiratory distress, pulmonary edema, raised BNP, or positive fluid balance. Right, so TACO, trali, FNHTR you should know. Okay, next, what is massive blood transfusion? In adults, it is defined as replacement of more than one blood volume in 24 hours or more than 50% of the blood volume in 3 hours. Okay, in children, it is transfusion of more than 50% of total blood volume in 3 hours, or transfusion of 100% of blood within 24 hours. Most common cause of bleeding in massive blood transfusion is dilutional thrombocytopenia. Most common abnormality, acid-base abnormality which occurs is metabolic alkalosis. So beta, this definition has come as a question, so please learn it. Next, what do you see when you get massive transfusion? We see hyperkalemia, hypocalcemia, hypomagnesemia, DIC, dilutional thrombocytopenia. This is the most common cause of death. Right, then hypothermia, and most common cause of death is dilutional coagulopathy, DIC, which leads to thrombocytopenia. Right, so please remember. And metabolic alkalosis, which may occur due to citrate. which has been added into the blood. Now let us come to ABO blood group. It is inherited as a Mendelian dominant. It appears in the 6th week of intrauterine life. It is not limited to the RBCs, the antigens, but it is also present. The antigen is also present in the saliva, pancreas, kidney, liver, lungs, testes, semen and amniotic fluid. Why antibody is present in plasma? See beta, if this is the RBC, antigen is present on the RBC, whereas antibody is present in the plasma. Right, I hope you know this. Antigen is also known as agglutinogen. Antibody is also known as agglutinin. Why antibodies are present in the plasma? Because which are the antigens? You know, they are not just present in the RBC, on the RBC surface, but they are also present in the common food. So when a child eats that food, then antibodies develop. Okay, now antibody is an IgM of the ABO blood group. It cannot cross the placenta. It is a cold antibody. What is Landsteiner law? We have two Landsteiner laws. What are they? Number one is, if a particular antigen is present on the RBC surface, the corresponding antibody is absent. And number two, if a particular antigen is absent on the RBC, then the antibody, corresponding antibody will be present in the plasma. Now this second rule is not followed by the RH. Okay, maximum ABO blood group in India is B, whereas in the world it is O positive and obviously B positive. RH positive is more than RH negative. RH positive is around 85%. Minimum in India and world is AB. Right, then you have to know that the ABO blood group is used for the parental dispute. Like for example, in this question, suppose the mother has A blood group, the father has AB blood group, then either the mother can be AA or AO and the father is AB, so father is having AB genotype. Now this particular person cannot have O blood group. He can have what? He can have A, AB, AB, B, but cannot have O blood group. Okay, how? You have to make do the cross matching and find out. Right, so these kind of questions can come. Okay, next is, how are the ABO blood group formed? See beta, every blood group has H antigen on RBC. If H antigen is absent, then we call it Bombay blood group. To the H antigen, if a particular enzyme acts, it forms blood group A. If galactose is added, blood group B. If both N-acetyl galactosamine and galactose are added, AB group. If neither are added, O blood group. Having said that, what does that mean? It means that A blood group has A antigen on the RBC and H antigen on the RBC. Right, it has anti-B, the opposite antibody, whereas the B blood group has B antigen, H antigen is present, and it has opposite antibody, anti-A. AB blood group has A, B and H antigen, whereas no antibody is there in the plasma. That is why please remember that AB blood group is a universal recipient, right? And O blood group has only H antigen, no other antigen. A and B are absent, but anti-A, B antibodies are present in the plasma. So that is why O is universal donor. And which O? Obviously first is the O negative. Bombay blood group, we don't have any antigen H, A, B, and we have A, B and H antibodies. So having said that, Bombay blood group cannot receive blood from any of the blood groups except Bombay blood group. So a person who's having Bombay blood group can only take blood group from a Bombay blood group person or from himself. So they have to keep on giving the blood to save, right? So what is Landsteiner law, everyone? This is very important. Landsteiner law. There are two laws which you should know. The first one is, if antigen is present on RBC, corresponding antibody is absent from plasma. Second, if antigen is not present on RBC, then corresponding antibody is present in plasma. Both the laws are followed by the ABO blood group. This second law is not followed by RH blood group. Understood? Okay. Next, beta, this is the forward grouping. In forward grouping, what do you add? In the forward grouping, you are adding the anti-sera. Right? Anti-sera. In the reverse grouping, you are adding the RBCs. Right? So that is the difference. So forward grouping, please remember, if you have A blood group, then if you add anti-sera A, then it is going to agglutinate. Anti-sera B, it is not. Right? For O, even if you add anti-A, anti-B, it is not going to agglutinate. For B, if you add anti-sera B, see, let us take one example. A blood group has A antigen and B antibody. Right? So when you add A anti-sera, right, A antibody, we are going to see clumping. Right? Similarly for AB, if you add A anti-B, then clumping is going to occur. One more thing which you have to learn here is RH. RH, D is the genotype which we are using. So when we add anti-D and clumping occurs, it is RH positive. If clumping does not occur, then it is RH negative. Am I clear? Now let us see few diagrams. Okay, see this. Now see this everyone. O positive. When anti-A, anti-B are added, there is no clumping. Anti-D when it is added, because it is positive, it is showing clumping. Right? So this is O positive. Let us see for A negative. For A negative, when you add anti-sera A, clumping occurs. Anti-sera B, no clumping. Anti-D, no clumping. So it is negative. So give me the answer of this particular question, everyone. Give me the answer of this particular question. This is the slide shown. I added anti-sera A. Clumping was seen. Anti-sera B, no clumping is seen. Anti-sera D, again clumping is seen. So what is the answer? Is it A positive, A negative, AB positive or AB negative? Obviously beta, it is A positive, because clumping is occurring with anti-sera A and anti-sera D. Please remember, in forward grouping we are adding anti-sera, whereas reverse grouping we are adding the opposite. We are adding the RBCs. Okay. Next, so opposite is going to be C. You remember forward grouping, because that is going to be the question asked. If reverse grouping is asked, remember it is always the opposite. Okay. Next, let us see this question, everyone. A 55-year-old male. So the question is, a 55-year-old male accident victim in casualty is having urgently needing blood. The blood bank is unable to determine the ABO blood group, as his red cell group and plasma group do not match. So what will be the emergency transfusion? Beta, the question is over as soon as they say they are unable to match. So when you are unable to match, then the best thing is you give him O blood group. Which blood group? Either you can give the O positive or O negative. O negative is better, but since it is not in the choices, so I have marked C, O positive. Okay. Next question, always remember, for donation O negative is better. Negative is always better. We don't want any antigens. Okay. Next, although more than 400 blood groups have been identified, the ABO blood group still remains the most important in medicine, because it was first blood group to be discovered. Yes. It has 4 different blood groups. Yes. C, ABO antigens are present in most body tissues. Yes. D, ABO antibodies are invariably present in the plasma when person lacks RBCs, the corresponding antigen. All 4 are true, but what is the answer? The answer is D, because they are invariably present. The Landsteiner law 2 is possible in the ABO blood group. Next, let us see how do you donate blood. So let us see, if the patient blood group is O, then what can be donor for the red cell? For the red cell, he can get it from O only. A, he can get from A and he can get from O. Right? B, he can get from B and he can get from O. AB, he can get from AB, he can get from next is A, right? Next is B and next is O. This is the pattern we follow. For AB blood group, first if AB blood group is available, we give AB. Then next best is A. Then next best is B. Then next best is O. So O is the universal donor. And of course RH negative. O negative. If RH negative person is there, you give RH negative. If RH positive person is there, any blood can be given. Right. So O negative is the universal donor. For the FFP, it becomes opposite. Right, a person who has O blood group can be given the fresh frozen plasma from O, A, B and AB. Please remember, for plasma, universal donor is AB and universal recipient is O. Opposite hai. This is opposite. Understood everyone? For the RBCs, we have universal donor as O negative and recipient as AB. So please remember either, and they are opposite of each other. So please remember, for RBC, for the plasma it is going to be opposite. Right. So if a person has A blood group, then the plasma which we can give him is A and AB. B blood group, B and AB. AB blood group, AB. Right, so this you should remember. And ABO is recommended for FFP but not a necessity. Again, if suppose this is the blood group, A positive is the blood group of a person, then he can receive blood from A positive, that is the first choice. A negative also can give, O positive and O negative. Okay, if someone is O positive, please remember he can get blood from only O positive or O negative. Right, because O negative to beta is a universal donor. Right, next B positive, please remember he can get blood from B positive, B negative, O positive, O negative. If AB positive, he can get blood from everyone. It is a universal recipient. Right, if someone is A negative, he can get blood only from A negative, O negative. See, what is the problem with A negative? Why we are giving negative? Because beta in A negative, RH antigen is not present. RH antibody is also not present. So we do not give positive blood if negative is present. Why? Because if we give a positive blood, to suppose a woman, then we will sensitize her. Right? This will make her prone for erythroblastosis fetalis when she gets pregnant. So for a negative, we prefer negative, but if it is not there, then we can give positive also. Next, O negative blood group, please remember he can receive blood from O negative. O positive also we can give, but then again sensitization issues will be there. B negative will receive blood from B negative, O negative. AB negative will receive blood from AB negative. A negative, B negative, O negative. Again, this is also a universal recipient, but negative is preferred. RH negative is preferred. Why? Because of chances of sensitization. So AB blood group is the universal recipient. O blood group is the universal donor. Understood everyone? Understood why we are preferring RH negative in a negative person? Right? Okay. Next. Next is RH blood group. Now it was also discovered by Landsteiner and Wiener. Landsteiner and Wiener also discovered the ABO blood group. So both the blood groups. RH antigen is D and antibody is anti-D. And we all know that DD, DD or DD. These two are RH positive. This is RH negative. IgG is a warm antibody. It can cross placenta. Since it is crossing placenta, it is able to cause erythroblastosis fetalis. Maximum are 85% positive, RH positive. Right? And RH negative are only 15%. Okay, next is hemolytic disease of newborn, which is also known as erythroblastosis fetalis. In this, the mother is RH negative. The fetus, the baby, is RH positive. Right. And how will you remember? Please remember, throughout the history the woman has been sabotaged, so woman is negative. So beta, please remember, mother is Rh negative, fetus is Rh positive. What happens especially during parturition, and mother is sensitized, so mother develops antibodies to the Rh antigen. In the second pregnancy, these antibodies can travel through the placenta and kill a baby, can cause erythroblastosis fetalis, connectoris. Okay, so first child is normal, it may cause hemolytic jaundice, erythroblastosis fetalis, connectoris. So how will you prevent it? Please remember, we will give at 28 weeks of pregnancy, Rh immunoglobulin has to be given, or within 72 hours of delivery of Rh positive infant to an Rh negative mother, we have to give Rh immunoglobulin. So these 2 points are very important. If suppose the baby is born with this erythroblastosis fetalis, then what do we give? Aggressive hydration, early phototherapy because jaundice is going to be there, early exchange transfusion which removes bilirubin antibodies.